Okay, so it's 12:15 and we're excited to be here with you all for our first live webinar for our community of practice for falls and physical activity. And today our focus is on strength and balance. It's clear to see that everybody's really passionate about this subject because we've had so many apply to attend the live webinar today. So we've got a jam-packed hour with some speakers that Alice is going to introduce to you shortly, but just a couple of things around housekeeping first of all. So we are expecting as you join in the live webinar that you are all on mute. We will unmute when any questions are requested to be asked, but that will just help with the webinar running if you can remain on mute, please. Okay, as I say, we are jam-packed for an hour and we've got lots to fill the hour. We've got the Mentimeter open for you to, some of you may have already heard me mention what does strength and balance mean to you in your work. If you can be thinking about that and completing that as we start, that would be great. And then we've also got some further questions to ask later on in the webinar. So welcome to you all. We're really excited that you're here. Have your lunch, settle in, have a drink, and let's hear all about what's happening within our community around strength and balance. Alice, would you like to introduce the speakers?
Thanks so much, Anne, for that introduction. It's great to see so many people coming in and joining us. My name's Alice Kilby. I'm well, I can just see somebody not on mute there. Would you, if you're not on mute, would you mind muting yourselves? Sorry. Thank you. I'm Alice Kilby. I'm a physiotherapist. I'm consultant therapist for falls prevention at Nutts Healthcare, and the community of practice is a really wonderful thing that we're all joining together to learn and share and hear about each other's stories. And that is what we're going to be doing today. Specifically focusing on strength balance exercises that are happening. We've got 3 different speakers who are going to talk to us about the work that they're doing around strength and balance in their areas. We've got Angela, who's from City Care, who's going to kickstart us with some of her reflections on the classes that are run in the city, how they're referring in to, working with others and how they're capturing outcomes, but also share some of the good, the bad, the ugly, the challenges and the opportunities. We've got members of social care. Carlo's going to talk to us in a bit about how they're adopting some of the principles of Otago and starting people on their journey towards a strength and balance exercises and really embedding that as part of their work. And then finally, we'll be joined by Sarah Davis, who's a independent exercise instructor who's running classes in the community too. So I hope we've managed to capture some different ways in which strength and balance is being delivered out there. And I hope that you'll gain something from listening and hearing from each of those speakers today. So without further ado, I'm going to hand over to Angela to further introduce herself and tell us a little bit more about what her and her team do in City Care. Thank you, Angela.
Not sure she's actually on the call yet.
She's not on the call yet?
No, just looking through the list. Carlo is. Should we start with Carlo?
Oh, thank you very much, Adam. Thank you. Carlo, sorry, we'd planned on Angela first, but
I've got my microphone on now. I didn't realise I didn't have my microphone on.
There we go. Oh, thank you. Unmute, the dreaded thing of Teams, isn't it, in finding that mute button. So let's go again. I'll introduce you again, Angela. I'll hand over to you to tell us about City Care. Thank you.
Okay. So I'm Angela Makin, and I'm an assistant practitioner and a postural stability instructor for Nottingham City Care. I've been a PSI since 2007. And I first joined the Falls team, as it was then, and we had one PSI and one group of postural stability sessions going in the city. And they started those because they were a small group, the small team, and obviously evidence shows that group based exercise programs are more practical and effective. And you can also see 10 to 12 people in that hour, whereas if you went to see the people at home, you would only you only see about 4 or 5 people. So it was more effective. And also we found that people who come to exercise groups are more adhered to the exercise programs. And they find, and especially with the Falls team, they find that they're not the only one that's fallen, because when you go into somebody's home, they always say, oh, I think I must be the only one who's fallen. But actually they come to the class and they realize that, you know, there's 10 people in here, and then, you know, there's we tell them that, you know, we're doing them in different places in the city, and they realize then that they're actually not the only ones, so they feel better then. So our referrals come from us, the rehab team. Occasionally we have them from the GPs and other services within city. So we did a few years ago a bit of a promotion on postural stability and where we're doing the classes, etc. So most of the teams in CityCare understand what postural stability is, and they refer in nurses, district nurses referring. We get a lot from those. We also get the patients refer themselves in, so they might have a friend or a neighbour or a relative who's doing these classes elsewhere in the country, and then they will ring up. We've had quite a few actually over the years who rang up and said, you know, I've had a fall, I didn't go to hospital, but my friend up in Sheffield is doing this, etc. So we get a lot from those. We also get some from the hospital. When they've had a fracture, they will refer in to us after they've done some exercises with them at their physio clinics. So first of all, what we do is we send out a GP letter, like a criteria letter to their GP with contraindications on whether they'd be suitable for the classes. So that would be uncontrolled angina, uncontrolled BP, any vestibular problems, and they have to be able to maintain seated upright posture as well, and sit in a chair without arms, because you've got to be able to stand up and stand behind your chair. So what we do is we write on the letter that we will presume in 2 weeks' time that if we don't hear from the GP, the person is suitable for the classes. And then after that, we add them to our wait list. So when we first started these classes, everybody started together, and it was a 24-week course. And that was absolutely fantastic, because everybody built up their confidence with each other. They were relaxed with each other. And then say on week 14, 15, we start doing backward chaining and floor work. And they all went down on the floor. Everybody went down on the floor at the same time. And we did backward chaining, but we also did balance exercises on the floor, strength balance. But we also played soft football, and they had good fun doing that. But now our classes are a 20-week course, and it's a rolling program, because, you know, we have so many people on the waiting list. People can't wait on the waiting list for 20 weeks before we restart. So we find now that people are more likely not to go on the floor, and they just watch me, or they watch some people who actually said that they would volunteer to go on the floor and do some backward chaining and some floor exercises. So that's the only beef I have with doing a rolling program, and I bang on about it all the time. But for practical purposes, we can't wait. We can't let somebody wait for 20 weeks without starting a class. So that's my beef over with. So just got to get that off my chest, just in case Tamsin's listening from CityCare. She might get going about that. Anyway, so once they've got to the top of the waiting list, we will send them out a health questionnaire, and then we'll also send them out a conf bowel questionnaire. So that is how they, oh my God, there's lots of people here. Yeah, so we send them out a ConfBal questionnaire and a health questionnaire, and the ConfBal is how confident they are. So it's things like, how confident are you about picking up something off the floor without losing your balance? So that would be a 3, 2 and a 1 scoring. So that would be, if you're not confident, it would be 3, slightly confident, it would be a 2, and then not confident, it would be a 1. So we send those out and then they bring them to us on their first week. We also do oh, I forgot what I was talking about now. We also do another assessment. So as a mobility assessment, so we do a timed up and go. We do a 180-degree turn, functional reach, range of movement. And then we do them all again after they finish the 20 weeks to see how they've improved. And everybody improves on something, whether it's their confidence, balance, flexibility, etc. So our sessions are an hour of exercise. So we do 15 minutes of warm up and stretches, 15 minutes of endurance exercises standing behind a chair, and then 15 minutes of balance exercises, and then 15 minutes of TheraBand exercises. So that's a resistance against your muscles. And we also do a warm down, and we do some Tai Chi at the end, and then we do laughing therapy. So we've just added the laughing therapy in because we used to work a lot closely with Asian community, and we did classes with them, and they would say, okay, that's fair enough, we can do Tai Chi with you, that's no problem. But in our culture, the equivalent to Tai Chi is laughter therapy. And they said, you know, we used to go out in the squares or in the parks and do laughter therapy like other people would do the Tai Chi. So we said, okay, well, fair enough. So we do a little bit of that. So you end up the class laughing. So that brings everybody's spirits up, and they're very cheerful then. So we've always kept that in. And then we do half an hour of a social side. So they have a cup of tea, and then that's where everybody gets to know each other. We get to know the patients. We also do educational talks. So we do about 8 of those. And they're about environmental issues. So we show pictures of hazards in the home, pictures of clutter, trailing wires, just to make sure that you've got a clear pathway going through to room. And then that gets a big discussion going. Mats are our nightmare. Yeah, so then they realise, then they put that back into their own house and think, oh yeah, well, this is a risk of fall. You know, I'll move that, and I'll, you know, move this around. We also do a bone health quiz. So that is that gets people talking as well. But we also take out with us, because it's visual, like an aero bar and a crunchy bar. So you'll all know this, like, about, you know, you cut your aero bar in half, you've got the holes there, you press the hole and it's okay. So that's the bone inside the calcium. Then we cut through the aero bar, so you still got your holes of your strong bones, but if you press it, it disintegrates. So we say, you know, this is an osteoporotic bone, etc. And then this is why we do our bone loading exercises, to improve that, to get your, you know, your bones and maintain what you've got in some cases. So that gets a big discussion going. We also do a nutrition and calcium quiz, and we give out leaflets and information. We give out importance of medications, when to take them at the correct time, 6-month reviews with your GPs, and we give out leaflets for that as well. We also give out the warm weather and the cold weather. Obviously, we're not giving out the warm weather at the minute. So things like, you know, shutting your curtains and that sort of thing. And we also do a little safety talk without frightening everybody to death, about, you know, keeping your door locked, don't answer the door after a certain time, that sort of thing. But also in this class, in this session, it's really important to talk about what people's goals are, realistic goals, where they would like to go. You know, we had a group a couple of weeks ago, they said, one lady said, I'd love to go to the cinema, but I haven't been to cinema for years and I don't feel confident. I don't know where the buses are I would go. And she just felt uncomfortable going on her own. So some other people said, oh, I'd like to go. So we found out where the buses were and what times. And then they come in the week after and they say, oh my God, we went and saw this film and it was great. And then we went for a coffee after. And you think, well, that's amazing. But then they come back and tell everybody. And then they all say, oh, you know what? I think if Julie could go, I could go. And then now we've got a little gang of them, there's 7 of them, and they go after the class, because we do a class in Derby Road Health Centre, which is on Derby Road, and opposite there is the old cinema, the Savoy, if anybody knows where that is, and it's cheaper as well. So they finish, they have a cup of tea, and then they go to the cafe, and then they wait there until the cinema starts. And this is what it's all about, isn't it? Getting people out and about, getting people's confidence up, by doing balance exercises and flexibility and etc. We also have done in the parks, there's some equipment, exercise equipment. So we've had people before saying that they'd like to come and do some exercises out, but not in a gym environment. So we've taken people out before, taken them to the park, and then they go to the park, and then now they meet now at 9 o'clock in the morning. So there's no kids around and all the rest of it, because nobody's up at 9 o'clock in the morning if they didn't have to, except older people. So they go and that's like their little clique and their little group that they go to. The only thing now is, years ago, we could refer people to the YMCA. There were so many different exercise classes or activity classes. Nordic walking, that was really popular years ago, but now because of budgets and things, there aren't that many places to send people forward to. So it's more, for us, it's more of getting people together and then deciding to go into town. We have a little group that go into town on a Tuesday, a couple of days before the classes. They have a little gossip. Age UK do a little group. I think it's for bereavement. I think it's something to do with bereavement, but if they've had a bereavement, obviously, and then they'll click in and they'll go with those other people. And it's really nice, because then you see that your work that you've helped them with and you've supported them with is amazing, and that's the job satisfaction is fantastic. So without me keep going on, because I do go on it, but we had a man and he came to the class and he had a fractured knoff, and you can't see me, I'm just seeing, and he came in with 2 crutches, and he said his goal was to walk across the fields, his brother's field, to pick up his potatoes, cauliflowers and cabbage. And we thought, oh my God, this is never going to happen, because this man is so ropey on his legs. But so he came in, and gradually over the weeks, he had 1 crutch, and then he would walk around the venue without a crutch. And then on probably week 18, 17, 18, he came in and he said, I'm bursting to tell you this. You've never guessed what we've done. We've done at the weekend. Well, I don't know. I went to my brother's farm and I picked my cabbages and my cauliflower and my potatoes. And you think, you know what? That's what it's all about, isn't it? And we have lots of things like that, little things. Last week we had a lady, she said, oh my gosh, I was able to, she's on week 16, she was able to fluff up her duvet. So before the weeks before, she was folding her duvet down, but now you like to fluff your duvet. And she said, you know what, I could balance enough, and my balance had improved, that I can fluff my duvet now, and get it all nice with her cushions and all that. And it's the little things like that's what it's all about, isn't it? And that's why postural ability is so fantastic. I'll shut up now, because I've probably gone on. But I could talk to you all day if you want to stay behind.
You stuck to time perfectly, Andrew. I love those stories at the end, and I could see smiles on people's faces here. You're right. That is what it's all about. It's that rehabilitation and that ability for people to improve no matter their age, no matter their stage of frailty. Yeah. I loved hearing about how you're building that connectivity, and I can see there's some questions in the chat about that. What I think we'll do is build up all the questions as they go along, and we're going to bring Carlo in next to tell us about the work that he's doing. But huge thank you, Angela. I can feel the enthusiasm through the screens. It's warm in my heart. It's just started snowing here in Retford. Absolutely wonderful way to kickstart this webinar. Thank you so much.
Thank you.
Carlo, over to you to tell us about your brilliant work that you're doing now. Thank you.
Well, it might not be quite as developed as the last speaker, but
that's what I want to hear.
So we're basically in obviously falls are really important because of our place with social services, obviously with either community referrals or hospital discharges, and obviously if we can help reduce falls, then it helps the NHS, and it just goes in that cycle, doesn't it? That we can reduce as well reliance on care. And care packages that we have to look for as well under the Care Act. So it obviously helps our joint working really with those in the health service. So around about 20 people went on the Otago training from the council. It was a while ago now because it was still in some restrictions we were under. So it was just coming out of restrictions. So about 20, there was occupational therapists. There were CCOs. For those who don't know what a CCO is, a community care officer, which is similar to your, I think, like your TIs or OT assistants, I think, in health. And there were some others as well that were asked if they wish to go and do the Otago training. Hopefully that they were in a position to sort of implement it within their services. So our service particularly, there was the majority, I think, were from sort of reablement services. So frontline services like myself, we're in reablement, so we go, it's home visits all the time, community based, to see a lot of people face to face. So there was people from predominantly from the different start teams, which is as I say, the reablement and the different areas of the county. There was home first response that are very similar to us, which is a shorter term service that pass on to us. So there was mainly ones that were going to be like obviously community based for front facing services. The process that we set up really is obviously by our nature we do a lot of observational and functional assessments with people to see whether we felt they were suitable to engage in the program. And I say it's predominantly Otago, but I'm going to talk about something else as well that we're trying to use as well. So we do the Otago. I got permission from New Zealand, believe it or not. I was in communication with New Zealand, the University of Otago, to make sure that we could use their literature. And we do their assessment. So we start with a sit to stand, the 2 minutes timed, and the standing assessment as well, to really work out whether the person's suitable for doing some Otago, because obviously they've got to get up from the chair a few times, they've got to stand, they can use, obviously, for those who know about Otago, can use some balance, they can hold on to, say, back of chairs or onto the mantelpiece and those sort of things. They can have some balance support, but it's more limited in Otago. And then we do the FES, a functional score, which is just 10 questions basically to get our baseline score of where they are. I've also created a folder with information about and a spreadsheet and some questions that we asked them to populate that spreadsheet. So Alice wanted me to include physio, so that's in there, whether they've got physio input, whether they go to external falls groups, and we collect this information at the start, because then what happens is on that visit that after we've chatted to them about whether they want to partake in the exercises, we will obviously go out, demonstrate, and when we'll leave the sheets that are in the Otago workbook, which have got very good diagrams. We don't think we'll reinvent the wheel because it's already there. And I say that it's open use. If anybody else wants to use those diagrams and using something else, you can use the ones in Otago, in the Otago booklet. So we use those diagrams that give instructions on how to do the exercises. We go through them obviously once with them, go through the whole exercise with them once. And then what we do is we do the FES and everything all at that point. And then at 2 months, 2 weeks later, we will visit again and we'll do the exercises again with them, just to sort of reinforce it. We are limited because, especially in start, we're a short-term service, so that's one of the things I'll talk about, the limitations with it. But we're after 2 months, so we'll go 2 weeks again, redo the exercise with them, see how they're getting on with them. If they've got any questions, obviously they can ring us at any point, and we'll keep the person open to us, and even if our service is finished, with our staff going in to help them if they have reabled or otherwise. And then at 2 months, we'd do a phone call review and do the FES, because the FES can be done without actually seeing the person, because it's just questions to get a score after that. And then we ask other questions, have they fallen within that 2 month period? Ask a few more questions to populate the spreadsheet, and then that basically crunches the numbers about, improvements, whether they've carried on the exercise or not carried on, whether they've got physio or no physio, falls groups or no falls groups. So when we do the exercises, it's probably takes about the session probably takes about 30 minutes. I would say we're trying to include the Otago, some of the warm up, some of the strength. We don't use the weights because we couldn't get the weight. That's one of the other limitations. We couldn't get weights for everybody. We couldn't purchase loads and loads of weights and just leave them with people, because we can't collect them again and leave them with people. So we have to use TheraBands. So that was another issue that we had to look at, is how to try and recreate the resistance parts of Otago with TheraBands. So I've been talking to colleagues in different meetings, looked at lots of YouTube videos, and we can pretty much recreate most of them. I think there's probably one that's a bit more difficult, that's a bit more complex to do to try and recreate, but mostly you can recreate them with TheraBands, and you doing them seated as well, all the resistance ones seated. Then we obviously have the balance part of the exercises, and then we try to include the cool down and stretch, but it's a lot more cut down than the full Otago, and I appreciate the full Otago. It's a lot longer than that, but I'll explain why we've obviously had to do that as well. So as I say, the spreadsheet crunches all the numbers. I've done a load of graphs. Hopefully, we're all hoping that we see the difference between those that haven't continued exercise or not taken them up, between those who have or have got other inputs as well. All I can tell you is there's only 3 people on it at the moment, I'm afraid, but it's all positive, because after 3, they've all improved, they've all continued the exercises, and none have fallen within the 2 months period, and all of them were previous fallers as well. So that's positive, even though it's 3 out of 3. Obviously, that's one of the things we're working on now, is to encourage the teams to, even if the person isn't suitable for the exercises, even if they don't think so, they can still be used in the sort of getting some statistics, because if they've fallen before, they can still be used to get some stats on other things, because sometimes we have physio involvement, even though if we don't think they're even suitable for the exercises. It might be because they're using some walking aids, we don't think they're suitable for doing the Otago, but they could be suitable. Obviously, we might be referring to physio, and that's still important. And then later down the line, they might be going to things like falls groups and things. So they're important. That those stats are important, even if people don't take up the exercise or even continue them. It's still nice. It's nice to get the data. The other part of the exercise, we're not just leaving it to Otago, because a lot of the staff haven't done it, obviously, is the get up and go, using the get up and go leaflets. So that's something we're trying to do at the moment. We're trying to encourage those who deliver the get up and go exercise, which are very similar to Otago. If you see, it's 6 exercises, very similar. We have all the leaflets and the booklets, and we want to encourage those that haven't done Otago to actually do that. If that's what they're comfortable in delivering, then to do that as well. To use the same assessments to make sure to do the sit, stand, and the standing, because that's important, obviously, to make sure the person's suitable. And it also helps the sort of the reasoning, the clinical reasoning behind who's chosen to do that, who they think is suitable. But as I say, we want to include the get up and go, and I've got it on the spreadsheet, but just as a target or other exercises, which basically means, but it's open to others then as well. It doesn't just limit it. And we have a monthly, I've just changed the name from, it was a Targo peer support group, and I thought that's a bit non-inclusive, so I've changed it now. It's just the Ms Falls peer support group now. So that's going to be going. I'm going to do a little. I feel like I'm doing a tour. I'm not doing not that grandiose. I'm just going to the different teams. I'm going to go to the different teams and go and talk to them about it again to try and reinvigorate, and also so they spread the word that it's not just people who've done the Otago training to be involved in it, and to try and, you know, build a bit of momentum and a bit of enthusiasm for doing it. So I've created this folder with resources. I've got the spreadsheet in instructions on how to go through the whole process, what assessments to do, links to YouTube videos, links to other literature. We've got Otago champions in each locality, north, mid and south. I've got locations of where the TheraBands are stored at each locality. And I've also got a spreadsheet now. When I get information from other groups, I don't necessarily attend them, but I get information on where all the falls groups in the county are. So I've separated that into mid, north and south and county wide. And I've got lovely links like the one with all the pins on the map. That looks, somebody thought I'd done it. I had to say I can't take credit for that. The Google map with all the pins of all the falls groups. So that's the thing. So as for limitation and barriers, as you've probably worked out, if we're doing a Targo, it's a lot of a longer process. It's usually the 12 months and weekly groups, and it works better in groups as well, you know, where people are attending together. I visited one in Derbyshire to have a look at it, and that was running very well. But we're limited with the service. So one of the limitations, of course, is the people that we see. A lot of the people we see haven't got the mobility, you know, the ability to do the actual exercise in the first place. That's one of our problems. But as I say, we're going to try, as I say, I want to try and encourage people to include them in the study at least, even if they're not suitable for the exercises. But we're trying to get people, I think there's also a thing of being a bit risk averse and including people that probably can be included. And I think that's something, and that's one of the things, it's been a gap since the training, because it was during the pandemic sort of thing, and actually implementing it took a while to get it sort of rolling. So that's why it needs a bit of an impetus again, a bit of an injection of enthusiasm. So we're not able to deliver the whole program, so we have to cut it down, obviously. And that obviously means it can't be as it was before, as it is with the Otago. It's obviously standardized and it's evidence-based, and we know we can't do that. The reason Otago was chosen over anything else was, of course, the other option was chair-based, which probably meant that everybody could do it. But of course, you're not standing, are you? You're not standing, you're not doing balance, so you're not really reducing that if you're sitting down all the time. Of course, we know that just the strengthening would help, but that's why we went with Otago. That's why that was chosen. So that's it, really. I hope that gives you an overview of what we're trying to do. As I say, we're still a bit, as I say, even though it's been a while, it's a bit of a, you know, still to get going, I would say. I say we've only got 3 people on the spreadsheet, and that's what I'm trying to do, is to tell people to get more on there, and to try and include more people. So thank you.
Thank you so much, Carlo. It's great to hear of different teams doing this sort of work as well. It's really interesting to hear how you're collecting that data and measuring those outcomes. I'm actually going to come to you've sparked so much conversation in the chat, Carlo, which is wonderful. So I'm just going to come through to some of the questions now before we move on to hear from Sarah. First of all, I'm going to tackle this one around the access to the map with all the pins in. Carlo's quite right. That's something that was developed by the team at Active Knots, and as part of the work that we do here in the community of practice. we're building this picture of where activity is happening across Nottinghamshire, and with that map that Carlo referred to is available through the Futures platform. Adam's or one of the other project team members is going to put the link to the NHS Futures platform into the chat now for you all. I would encourage you to sign up to this Futures platform. This is the way that we're hoping to connect people outside of these forums, for you to continue to share and learn from each other's projects, but also to connect with each other outside of our more meetings or our webinars. You don't have to have an nhs.net or an NHS email account to be part of this platform. One of us will just approve you if you're signing up either from social care email addresses or your own personal email addresses. We can just approve you to be part of that platform. On there, you'll find a wealth of resources, including that map that Carlo referred to in terms of the where strength and balance activity is happening. I'm just going to have a quick scan of the chat now to gather some of the other questions. Lots of interest in your service, Carlo. Would you mind just telling us a little bit more about the team that you work with and the members of your team who are trained in Otago and where they're delivering their services, please?
Right, so I'm in the short-term assessment reablement team called START for short, and there's 3 teams basically. The START team. There's one in the north, which is in Newark and Bassetlaw. There's one in the mid, which is Mansfield, Ashfield, and then the south team is Rushcliffe, Gedling, and Broxtowe. So basically, what we do, we've been split slightly a bit because we've had another team's created as well, which is called the CRT team, Community Reablement Team, and they take referrals now more based from community. We used to do community and hospital referrals. We still get some, obviously. There's a bit of crossover. But we are mainly based with the hospital referrals now. So we refer to people come to our service, and we have a number of what are called we used to call them peripatetics, but it's so complicated that it's basically senior workers that go out and they do initial assessment and do like a care and support plan. We don't like to use the word that we're carers, because that's going back to the old days when everything was done with people. So we like to think about we're reablement workers. So our workers go out and actually work with the person, do with them, not do for them. So that's really important, how things have changed in social care. So the seniors go out and do the initial plan. They do things like, I think you've already mentioned about things like whether they want to talk to the crime reduction agencies, they do the fire service referrals, they do all those as well during that first initial, and that can take quite a long time when they're setting up the care plans. What the calls are going to be, the support calls are going to be, and how long, the frequency, those sort of things. And they create the initial activities task list really for the other ladies going in. Then the reablement workers go in. They do the actual work with them, and then we go in as occupational therapists or CCOs, and we're the ones that will be the ones that be doing any Otago with them. So we go on, obviously, do our own assessment, set goals with the people to try and make them independent. I think we're up to like 75-85% leave our service with no ongoing package of care. Our aim, obviously, is not only for their benefit. Obviously, it's a benefit not to have ongoing care for people. People think sometimes they need it. Well, actually, sometimes it's obviously better if people can do it for themselves. If we can do that, if we can facilitate that. So we do. We have small aids, equipment like very simple things like long handle sponges, sock aids, dressing sticks. We have assistive technology like medication reminders, medication carousels, timers, those sort of things. We have quite a range of things that we can draw on. We even have like a little small falls budget reduction. So we have night lights, pet collars with bells on, those sort of things. We even have access to those sort of things now as well. We've got a range of those things so the mats are stick down. The tote socks, with a sticky sticker. We have access to those sorts of things as well that we can give out during our service if we think they're suitable. And it'll be during our visits, because we usually we at least be there at least 3 weeks probably as a minimum. Sometimes people are able very quickly and they might be in and out, but if we identify it during that time, we've been given the opportunity to go back even if our staff have drawn out. So if our staff have withdrawn given the actual reablement clause, we can still be involved. If we've identified it as an OT, it's the same as an equipment review. If we identify equipment while we're in there, we don't just say, well, we've finished with you, we're not with you anymore, so we're not going to go back in. Of course, if we've identified while we're there, we'll go out, do the equipment, you know, follow up on the rails, make sure everything's, you know, that the person's happy, that it is actually being fitted correctly. We would still do those sort of things, and the Otago is going to be part of that. So part of our regular visits, probably not the first visit, but on subsequent visits, if we think we identify that they're suitable for it, then a subsequent visit we can introduce it, because review visits don't usually take as long as the initial visit, and then we can introduce it, and then we'll say we're going to do a 2-week follow-up to sort of really see that the person's happy with what they're doing, ask any questions, go through it all again, build an enthusiasm in them to continue. I think that shows that you're bothered. If you go back in 2 weeks, it's showing that you're bothered about it. And also say that you're going to follow up in 2 months to see how they are, to do that phone call. So that's how it works, and that's how our service works. So
thank you.
We reduce. Sorry, no, go on, Alice. I think I'm going on too long.
No, we've caught you on full enthusiasm mode for occupational therapy in reablement services. Thank you. It's great to hear how those combination of things are all moving towards preventing falls in the people that you care for and look after, and how the exercise element is one element of that falls prevention piece. You've really clearly explained that there. Thank you. I'm going to come to Sarah now, and she is an independent exercise instructor who is running classes in the south of the borough, and I'm going to let just Sarah do her thing, because you will see very shortly why I'm saying that, because she's running some really successful classes, and we're really pleased to have her here today to hear a little bit about how she's adapting exercises to individual needs, facilitating that sense of belonging, and also how she's overcome some of the challenges in setting up classes from scratch. So thank you to Sarah.
Thanks very much. So I'm a postural stability instructor, and I'm delivering back-to-back 12-week standalone classes for the Fracture Liaison Service in East Bridgford and Cotgrave. I'm also delivering ongoing falls prevention and management classes in Calverton and Netherfield. And last year I got some seed funding from the Health and Social Care Ageing Well programme to deliver initially 12-week pilot classes in Arnold, Carlton and Mapley, with a view to these carrying on afterwards. So these ran from September to December. Participants paid £3 a week. The classes worked, so they're continuing. So participants are continuing to come, and they're paying £5 a week now. And the classes will run very much on the later life training falls management by exercise format, i.e. there's 60 minutes of exercise. So that's either seated or standing. Everyone has a chair, so you can sit down, you can stand up behind the chair, you can do a mixture of the two. And they're evidence-based warm-up, endurance, so you're working your heart and lungs a bit harder, as well as working on coordination, strength of legs and arms, balance exercises, strength exercises using TheraBands, also do backward chaining down to the floor, exercises on the floor and back up again, adapted Tai Chi, and then stretching at the end. So 60 minutes of that, followed by a 30-minute social session, and then encouraging the participants to do exercises at home at least a couple of times in between the group exercises, and we use the PSI home exercise booklet for doing that. I also give out the Get Up and Go booklet. And as Carlo was saying, I do some assessments week 1 and week 12, just to kind of like track progress. So we did the confidence and balance and fear of falling questionnaires with them, and also the functional assessments or functional reach, timed up and go, and the 180 degrees turn. So at the end of that initial 12 weeks in Arnold, Carlton and Mapley, 91% of the people that completed the 12 weeks are now carrying on the maintenance classes, or if they feel confident, they've joined other classes. 70% reported an increase in their strength and balance. And then we've got a massive 97% of them increased knowledge of how to get up from the floor on their own, which is massively important because it means that they're preventing long lies. So if they fall when they're on their own, it is safe for them to get up. They can get up, so they're not lying on their own. They haven't got all those kind of physical and mental health repercussions of that. Also, if they can get up on their own, they're not kind of like relying on somebody else to try and get them up who might damage themselves or fall over as well. And they've got two people on the floor and that doesn't help anybody. So that's really, really important. And that's just the beauty of the PSI class, that you can get people to do that. Then they're also helping them to live a more independent life. So lots of people saying, oh, I can get down and tie my own shoelaces now. I can put my own socks on. This is so liberating for them to do that. They can stand up to do their housework. They can do their cooking. They decorate the Christmas tree. Haven't done that for years. They can go on the bus. They can go shopping. They can go out for a treat. I mean, it's so exciting just hearing about how it's transformed their lives. And that is the other really important thing, that by coming along to these classes, they meet more people. Really important if they're living on their own and they've been socially isolated, particularly after the pandemic. And they're joining friendship clubs, coffee mornings, walking groups, lunches, knit and natter, singing groups, you name it. So great, it's worked. We know it works. It works. And my key learnings from doing this. There was, I think it was a bank, wasn't it, that used to have the strapline, think global, act local. And it's this acting local that is really, really important with this. So my local partnership with Gedling Borough Council really helped with promotion of what we were doing, using their electronic health and wellbeing newsletter, which just went out to so many residents. Also the Gedling Seniors Forum, so all their contacts on that. And what we found was that people like from the U3A and Churches Together were then sending out with their networks, and then it spread by word of mouth. So Gedling Borough Council were absolutely key to promoting this. Also, my relationship with the Primary Care Network Development Manager was really good, because then we had access to the clinical director meetings, to MDT meetings at the doctors, getting in touch with the practice nurses. Then also a connection that I had with the local physios, so with the Notts Healthcare physios in the area, the first contact physios at the GP surgeries, and the Connect Health physios. So they've all helped again promote it and refer in. And then the social prescribing link workers, so I've got good relationship with them in the locality, and also the local adult social care community care officers, and the promoting independence work. And as Carlo was saying, there's been a big shift towards trying to have a strength-based approach, trying to enable residents to get out and take responsibility for their own care. The promoting independence work has been brilliant in trying to encourage people to come along to the sessions, maybe attending with them on the first day, then meeting them there the second week, and then gradually they build up the confidence to come on their own. So yeah, massive learning, act local, really, really key. So you're building within local communities rather than trying to helicopter something in from outside. Our second massive learning was using community hubs as venues. So these are known safe places in the community. People know where they are, they feel comfortable going, and they're easy to access. They've got bus stops there or car parks, they're flat. And then other things that are going on there. So lunches, coffee mornings, maybe a food bank, cost of living advice, knit and natter groups, friendship clubs, citizens advice bureau outreach. So there's, maybe the first step for them has been coming out of their house and coming to the classes. Then they build up confidence, get to know other people, and then they think, oh, I could go to that friendship club that I can see information about, because now I know that place and now I know people that I can come with. The other thing from my point of view as an instructor is it's quite nice to actually run something in a community hub where other groups are, or if, say, like in a church building, if you've got the church secretary there sitting in office, I'm not isolated and lonely. So if something was going to happen, if a participant was ill, if they did have a fall, there's somebody else there to help. You know, if they get down to the floor and can't get up again, there's somebody else there. I don't feel kind of like stuck out on a limb. And the other thing is that you know, sometimes they've got a taxi maybe coming to pick them up afterwards. If the taxi doesn't come, you know, it's very difficult me hanging on and staying with them because I've got other classes. Like, you know, today I've got 3 classes. And so if I have to stay waiting with somebody, and obviously I'm never going to be leaving somebody on their own, then that means that everything else that I'm doing during the day is affected. So if you're in a venue where there are other people around, then that really helps support you. So yeah, first is all about acting local. Second is the value of the community hubs. And the third thing is engendering that feeling of belonging. I tend to call my classes the strong and steady crew. So you're part of something. This starts right from the very beginning. So on the poster, I have my name, my phone number, my email address. So referrers know that they are referring to a named person. They're not referring into a black hole. So they've got my contact details. They can contact me. And then when I contact the individual, then I email back to the referrer just saying, you know, this is what I've done. For a participant wanting to self-refer in, they've got a name of a person, they've got the phone number, so they're like talking to somebody. I then ring them, and of course, because it's just me on my own, I can ring them really quickly, and I just answer any questions that they have, and then go through a health assessment to make sure that, you know, that the classes are going to be appropriate for them. Now, because I know the classes, because I'm instructing them, I can also talk to them about the venue. So I can say, yes, there's the car parking. Yes, there's a bus stop there. Yes, there's the toilets around the corner. Yes, it's flat to come in. These are the type of people that you will be with on the class. These are the type of exercise you're doing. Yes, you can sit down if you want, you can stand up, or you do a mixture of the two. And then the other thing about me talking to them is I can start building the relationship with them and start just finding out a little bit more about them, which really helps. And then, of course, the first day they come along and they see me and the person they spoke to on the phone. So they're not coming cold into a room. They've already got somebody that they can come and see, which really helps if this is the first time you've come to something. So the other thing I do is trying to listen to what's going on with people. So what they've done in their life, you know, did they used to play the organ? Did they, I don't know, go fell walking, whatever. It's quite important to have that bit of knowledge, because you can then bring it and build on it when you've got the class. So for example, in the dynamic endurance part, we do fartlek, we do 3 big marches. So I try to make it kind of like local to them, applicable to them. So I can go to Gedling Borough Council, sorry, Gedling Country Park, or I walk along the river in you know, Burton Joyce. So it's somewhere they know, so they can then kind of talk about that. They can share their memories of it, and also it kind of like makes them think about, oh, I could actually go back there again. Yeah, I'll do that. I also think, like, if there's somebody who lived in the Lake District, you know, we'll go from Grasmere and go up to the Tarn and the cairn at the top. If they liked going with their husband and dog to Scotland, we can recreate that. So yeah, it's just trying to get them to share those lovely memories. And then that just engenders lots of things. So people bring their photos in, they bring little booklets in of when they used to go there. Make it current as well. So last week, St David's Day, we went up Snowdon, we shared knowledge of our Welsh language. When the daffodils came out, we were reciting Wordsworth's Daffodils poem. We share farming knowledge as we're walking along the river. We went to the Austrian Alps and we sang loads of songs from The Sound of Music. My voice is fairly rubbish, my singing voice, but then everyone else starts singing. And it's particularly valuable for maybe someone living with dementia who can't really remember what their name is or where they live, but suddenly they know all the words of the songs. So that's a lovely way of bringing it in. Also tailor and adapt the exercises to the participants. So just gently getting them to progress what they're doing. So for example, if they've they don't want to get down to the floor, I demonstrate it every week so that the instructions are like imprinted in their minds, so that if they do fall when they're at home or out and about, they know the instructions and they've seen me do it each week so they can get up. But obviously trying to encourage them to do that. So maybe standing up from sitting down to start off with, then maybe a couple of steps forward, turning around, lunge towards a chair. As the weeks go down, lowering the knee, then gradually getting all the way down. And it's incredible. So there's one lady on week 1, she was struggling to get up from a chair. Last week on week 20, she got down to the floor and up again 5 times, which is so excited she had to text her husband immediately. So that's one way of adapting exercises. I also use like bottles of water. So if people are struggling with like the say back and biceps with the TheraBand, I'll give them a water bottle, and then they can do the bicep curl, but just come up a little bit rather than all the way up if that's causing problems for them. I take towels and Pilates balls in, so if they're struggling with the inner leg squeeze with the TheraBand, they can use those. So lots of things to make everyone feel that they can take part. Social session at the end, massively important. So for a lot of people, this is as important as the exercises, particularly if they're living on their own or they're living with somebody who's got quite serious health conditions. So we use it to chat about anything and everything. We talk about other groups that are in the area, and people are signposted to different things. In Calverton on Monday, they all plan to go out for lunch. We talk about community transport and volunteer transport. People kind of, because they've got that feeling of belonging, sometimes bring in home-baked cookies and cakes and photos and words.
Sarah, yeah. It's absolutely wonderful to hear the great work that you're doing and all your passion. Absolutely wonderful. We've had some incredible comments and questions that have coming down through the chat bar there. I hope you don't mind me coming in there, Sarah, because we are running out of time for the webinar.
Can I do 2 more things?
Yes, you can.
Yeah.
Yes.
So we've got all that chatting going on. The other really important thing in the chat, in the social chat at the end, is it's a really good opportunity to pass over falls prevention and management things. So thinking about lifeline alarms, thinking about those night lights, thinking about drinking enough. It's much more powerful if people are sharing it from their own point of view than me telling them. Last thing on the kind of belonging thing is people like to help out. They like to feel a role, so it's, whether it's like washing up or putting out the tea and coffee and what have you. And that's one step along their line to independence. So yeah, that's the feeling of belonging. It's really good. These are amazing classes. People over the last couple of weeks have just said, I come in and I'm just smiling from the beginning to the end. It's a laugh to come to. It's helping me get up the stairs. It's helping me get down on my knee.
Incredible.
And one person said to me on Monday, which was lovely, I feel like a proper person in my own right. She's got dementia. All the children, like her and her husband, are making decisions for her. But now she goes into that class and as an individual on her own right. So there we go. The end. It's brilliant.
Sarah, I want to thank you from everybody. I'll have a point in pulling it together at the end, but absolutely wonderful. We've got huge smiles and lots of cheering in the background. Absolute wonderful to hear you talk about what you're doing. And we need more Sarahs. We absolutely do. We need to litter Nottinghamshire and Nottingham with Sarahs. And we're going to build on that work 100%. Key take-home messages. Feeling of belonging, massive, isn't it? Bringing it local and people being involved. Fantastic. There's so many comments coming through the chat. We're going to try and capture all of this. We're going to share it on platforms. And I think what's really important to mention now, as we only have a few minutes left of our webinar, is we need all of you signed up to our NHS Futures platforms. This is a space, a safe space for us to connect together and share what's really important and continue to build this momentum around encouraging physical activity. And as we know, by encouraging physical activity, we're going to reduce falls. We really need all of you on this call to have a commitment to support us at building this community of practice. It's thriving, it's developing. Seeing all of you here on the call is wonderful. We're going to share the, Adam's made a lovely how-to guide on a PDF, and we're going to make sure we get that out to all of you. It's ever so easy, actually. And as Alice has already said, if you've not got an NHS email address, we can allow you to be on the community of practice as well. So it's really straightforward. You know, we can get you all on, we can get you all continuing to connect and talk to each other. So much today that we want to share, and we want to continue to build on. So literally, you just search for on NHS Futures, you just search for the Nottinghamshire Falls and Physical Activity Community of Practice. Okay, and you can connect into that. We will send some further information out to you all about it. I want to just take the opportunity to thank everybody, especially the speakers today that we've heard from. A lot of diversity, but the messages are very, very channeled as well around the importance of encouraging independence, strength and balance. The 3 people we've heard from their teams, it's been wonderful to hear from them. And all of you here on the live webinar, we can't thank you enough for joining us. It's superb to see you all here. And I think that just proves to us all how important this is, how much strength there is in what we're trying to achieve moving forward all together as a community. Big thanks to Alice and Adam and Rachel as well, who were on the call. Are the ones now we need to continue to drive this work forward. Absolutely wonderful. So we're over time already. We've got 1 minute over. There's just one last thing really I want to share with you all as we end. So humans, we're made to move, aren't we? Yeah, we've heard that today. And the body will become better at whatever you do or don't do. So if we don't move, your body will make yourself better at not moving. And if you move, your body will allow more movement. Let's push the movement messages. Let's get people more active. Let's stick together as a community. Let's see where the next 6 months and the next year and 2 years takes us. Thank you to all of you. It's been fantastic. Again, to the speakers, incredible. All the best, everybody, and let's keep working together.
Thank you very much. It's been inspirational.
Thanks so much, team. You did a great job there.
Thank you.
So we
really,
are
really
closing.
Great. Thanks ever so much.
Thank you. We are closing the live webinar now.